Dr. Elijah, are you there?
Yes, I am. Yes, I am.
Okay. So how was your week?
Yeah, been okay.
How's the COVID situation?
Yeah, it's bad right now, actually.
Still not improving.
Not yet, but at least the vaccination seems to be catching up.
Oh, okay, good. You all had your vaccines?
Yeah, we're having it. Yeah,
Which one? The
AstraZeneca.
Okay.
Yeah.
You had both the doses or one?
One, just one.
Okay. Even one is sort of protective a little bit, but you still have to be careful because here we know doctors who had 2 doses who are still infected. But then most of them are mild infections, so it's okay.
Yeah. So it's made in India, right? The AstraZeneca one is being produced in India.
Yeah.
So you've had it longer, right?
Yeah, I finished the second dose almost 2-3 weeks ago.
Oh, second, okay. All right.
Okay.
So I'm sure then you have more experience with
No, but the numbers actually going up because they vaccinated only a very small percentage of the population. Yeah,
good evening.
Good evening, Dr. Celio.
Yeah, good evening.
Good.
Thank you.
Okay. So, Dr.
Good evening, Dr.
Celio.
Celio.
Yeah. Then shall we start?
Yeah, sure.
Okay, so you're supposed to do some homework. Did any of you do that?
Yeah, or One.Surgery?
Hmm?
The one on One.Surgery?
Yeah.
Yeah. So yeah, I went to do some topics there and did some quizzes. Yeah.
Okay. And were you able to do any of the, I thought that Elijah has completed about half the course, no? 50%
Yeah.
in the website.
Yeah. Yes.
And Dr. Celio, have you completed any? Because it says 0 there.
I knew that you sent certain message to me. I didn't go through the message.
See, if you go to the website, after each lesson, there is 3 buttons. One says mark as complete. So after you click that only, it will show to others that you're...
Is he registered on the One.Surgery?
Yeah, he's registered. Yeah.
Okay.
And then again on the left, there are one column which says quiz. So that also you have to go and complete.
Okay, quiz.
Yeah. It's a multiple choice, and then as soon as you give your choice, they'll automatically correct and tell how many you got correct. So before next class, we should do at least one quiz and mark one lesson as complete. Okay, so what shall we discuss for today?
Yeah, maybe UPJ obstruction.
Okay. So, Dr. Celio, what is UPJ obstruction?
Maybe retropelvic junction obstruction. You want to know what could be the cause? Yeah. It could be staghorn stone.
Okay, but even the terminal, before that, the terminology, is it UPJ obstruction or PUJ obstruction? Which is the correct word to use?
Okay.
Which is the correct one? Is it uretropelvic or pelvic ureteric obstruction?
I think it's retropelvic junction obstruction.
Yeah, see, you have 2 junctions. One is the pelvis, one is the ureter.
Yeah.
And we are talking about the junction. So is it pelvic-ureteric junction or uretero-pelvic junction?
It's uretero
Because what
pelvic
Elijah
junction.
said, why do you say that?
Yeah, I think anatomically it should be PUJ, but I think we are all used to saying PUJ. Yeah.
See, anatomically, why is because the urine is produced in the kidney and comes down.
Yes.
Okay, so then how does it travel through the junction? So ureter, normally ureter, is it an open pipe or is it a closed pipe? See, the kidney produces urine continuously. The nephrons, they filter and they produce urine.
Yeah.
Okay, so then what happens?
So it moves by peristalsis through the ureter.
Okay, so normally it is actually a collapsed tube. So only when the peristalsis, when the bolus of urine comes, and then the peristalsis sort of pushes it down. So that's how then the urine comes from the kidney to the bladder. Okay, and what controls this peristalsis? So how the peristalsis initiated?
Maybe by the urine.
Yeah, see, normally I said the kidney collects the urine. So it comes to the collecting ducts, calyces, then the pelvis, and then it has to come through ureter and boluses. So what controls this movement? See, does the kidney keep pumping or something like that intermittently, or what happens? How is this bolus produced? Because that will help you understand the treatment. Obviously, I don't know. So you take a guess.
There are muscular part of the ureteric wall that.
No, ureteric wall. See, once peristalsis starts on top, it sort of progressively contracts and pushes the urine out. See, with the tube like this. So when bolus starts here, and then it keeps contracting, pushing the thing down. So that is the automatic response. But when does the bolus start?
Maybe once the pelvis is full of urine.
Okay, so that means, you have different sizes of pelvis. Some pelvis, extrarenal pelvis are huge, about this size. Some intrarenal pelvis is very small. But see, this should give you a clue because we are talking about PUJ junction.
The gravity.
So obviously the answer has to do with the junction. See, the kidney doesn't really contract to generate the bolus. So kidney is fixed, and the urine keeps coming and collecting in the pelvis. So then it is the PUJ which initiates the peristalsis. So it opens up after a few minutes or whatever time that is necessary. There are reflex stretch fibers in the pelvis and the capsule, which sends signals to the PUJ, and the PUJ dilates. So once it dilates and fills, then it will contract and form a bolus, and that bolus keeps coming up. Okay. So it is the nerves in the PUJ which is responsible for this peristalsis, generating the peristalsis and making sure urine flows from the kidney to the bladder. So how does the congenital hydronephrosis develop? Have you heard of congenital hydronephrosis?
Yeah.
Okay, so there, what is the problem? In congenital, the hydronephrosis occurs from birth. What is the problem?
It's congenital stricture of the PUJ.
It's not exactly a stricture. If If it is a stricture, then it'll be a total block. It's like if you have urinary retention, urethral stricture.
Okay,
And,
let's say stenosis.
So this is basically mostly will be problem with the it's a neurological problem where the nerves are not able to generate the normal peristalsis.
Okay.
Okay, so then there is a backlog. See, normally if with a certain pressure inside the kidney. So now, how much is the pressure inside the kidney? How many centimeters of water? The normal pressure. You know that in the bladder, if you have to pass urine, it is about 60 centimeters of water. What about the pressure in the kidney? How much is the normal pressure?
Wild guess, 20.
Okay, you are fairly close. Is it less or more? The next guess, Dr. Celia.
I can't guess it.
No, you have only two options. Is actually more than 20 or less than 20? Only two. So which one do you think it is?
It should be less than the one in the bladder.
Yeah, obviously 20 is definitely less than the bladder. Okay, it is about 10 to 15 centimeters of water is the pressure in the kidney. Okay, so when the stretch receptors, the sensors in the kidney recognize the pressure is about 10 or 15 this thing, then it sends impulses to the PUJ to open. Okay, so then the urine flows out. But if there is a problem and the PUJ is not able to relax and send the urine down, then the pressure in the kidney builds up. So it can become 20, 25 like that. And that is the reason because of the back pressure, the kidney tissue, cortical tissue gets destroyed and it becomes hydronephrotic. Okay. So even though it is, you may not actually see any physical block or obstruction, you have block which is responsible for destroying the kidney size. So what do you mean? So how is it treated?
Pyloroplasty.
Okay, so pyloroplasty. Have you done any pyloroplasties?
I haven't done myself, but
okay. So maybe you read about Anderson Hines pyloroplasty or any other pyloroplasty. What do they do?
So, well, it can be dismembered, pyloroplasty or non-dismembered.
Okay.
So if it's non-dismembered, it's basically a bypass. Pelvis to normal ureter. Yeah.
But then we generally prefer dismembered. So what does it basically do?
You resect that portion that's narrow.
Yeah. So you have to see the important things is that you need to sufficiently remove the affected portion. Okay. So then what happens? Does it become normal and the rest of the ureter start generating these impulses, neurological impulses, or it just remains open? See what happens is so it's because that it's only the nerves which are found at the PUJ which have this special capability. So once that is gone, so once you remove, then it's like a regular pipe. But the good thing is that it reduces the pressure on the back pressure changes on the kidney. And the rest of the ureter is sort of used to, once the urine comes there, to be able to push the urine down. Okay. So this is the classical open surgery. You need to sort of open go into the retroperitoneal region, dissect the kidney, resect the PUJ, and usually you'll have a small portion which goes up and down instead of being straight like that. So you remove this thing. So you remove a wedge in the pelvis, then you open up the ureter and then anastomose. So why do you do this opening up the ureter and anastomosing?
To avoid stricture.
Yeah. So you need to, any healing produces scar tissue. So once you have a scar, once it heals, it will be narrow. If it is a circular area, if it heals, it will become smaller and stricture. So you don't want that to happen. That is the reason we make a cut in the, if this is the ureter, you cut and then bring the pelvic tissue and suture it so that there is enough gap. But then it is still doesn't work like normal thing. Okay, so then what are the minimally invasive ways of doing this? So they have a special big stents. There's an instrument which goes inside the pelvis. Then it has a wire which can extend and they can cut open the PUJ. Okay. And then they leave a very big sized stent which goes from the renal pelvis to the bladder. So what that does is, it'll stay in urinary leak and but then the stent will make the urine go up and slowly it'll heal. The transitional cell will heal around it. Okay, so then it sort of simulates the actual surgery, but then it's not 100% effective. Okay. Another the way of reducing the pressure is you just put an ordinary stent also. If you don't have the facilities for all these special stents and cutting the PUJ, sometimes just putting an ordinary stent, what does it do? If you leave it sufficiently, it makes the ureter dilate. So once it dilates to about 2 to 3 times the original size. So sometimes that itself, if it is a mild PUJ obstruction, sometimes that alone is enough as a treatment. Because you either need a specialized equipment and you need to be in a specialized center to do the minimally invasive treatment. Or you should have the capability of doing Anderson Hines or Pyloroplasty. But most of you can actually learn how to do stenting and leave the stent. But then you need to leave it for a couple of fairly long time so that the ureter stays dilated. So you don't want the ureter getting blocked again. But then normally the earlier stents, we can't leave it in the body for more than 3 months. So you have to keep, once you put a stent for hydronephrosis, you have to take it and put it again. But now they have these long-term stents which you can keep for about 6 months. But still, it's ideally you should keep it for about 2 years, so that the kidney recovers and there is enough dilatation so that there is no block. Okay, so this is for PUJ obstruction.
I didn't understand. What is the procedure called?
Which one?
The surgery, the surgical intervention. So
Pyloroplasty.
Okay.
Pylo.
I thought it was pylo because pylo.
No. Yeah, pelvis, renal pelvis.
Okay.
So you do a plastic surgery on renal pelvis. So it's called pyloroplasty.
Okay. Is it a triangular incision you make at the anterior part of the pelvis, or?
See, what you do is, you open first you find out the junction between the pelvis and the ureter.
Yes.
Okay, so then you remove a wedge-shaped portion of the pelvis so that it V-shaped portion.
Okay.
Okay, and then you split open and you remove excise the junction.
Okay.
Then remaining ureter, you make a vertical slit.
Okay.
So then it'll, if a round thing, if you make a slit, it'll open. Okay. And bring the pelvis into that splayed open area and then suture.
Okay. Okay.
So basically, you're widening the opening.
Okay.
And instead of the full ureter covering the thing, you're having part of the pelvic tissue also there.
Okay.
That is the Anderson-Heinz Pyloroplasty. But to do that, you have to open the big incision and open and all that.
At what age of the baby do you do that? At what age of the child do you do that?
See, the earlier you do, the better, because as long as the obstruction is there, it'll keep on destroying the kidney. And there's hardly any function in the kidney. Sometimes they'll be so hydronephrotic, you have to do a nephrectomy. So basically, it depends on your capability and how safe it is to give anesthesia. Okay. So normally they say that when the baby is about 10 months, it's fairly safe to give anesthesia. But even in the younger one also, if they have experienced anesthesiology, you can give anesthesia. But most centers, they can consider about 10 kilos or 10 months as a safe time to give anesthesia and do this surgery.
What of an adult that has adult with hydronephrosis? Adult with hydronephrosis.
See, adults also, it can be it can occur, the congenital one will be, although it is present from the birth, it can present to you only as an adult. It again depends on the severity of the block. Say the nerves will also function, it's not totally gone. So sometimes, say instead of once in 2 or 3 minutes, there is a peristalsis, which allows the bolus of urine to come down. But if it allows only once in 5 minutes, then it doesn't immediately destroy the kidney. It takes some time for the kidney destruction and enlargement to come. So hydronephrosis can occur even when it will present as an young adult often. But beyond that, if there is hydronephrosis, then it's as Dr. Elijah earlier said, it's maybe due to a stone. Because that's, if the kidney stone forms, the first area where it can get blocked is the PUJ junction. So sometimes there's a small stone there and some fibrosis and infection can cause hydronephrosis. So in your setting, you can try putting in a stent and leaving it for, say, if you think it is no stones, if it is because of PUJ obstruction, you can try leaving it for about 2 years. And if nothing happens,
2 years.
Yeah. So, but you have to keep on changing the stent. So same stent, if you have ordinary stent, every 3 months you have to change. So how many times you have to change?
4 times.
4 times? 8 times. 8 times, yeah. If you are putting an ordinary stent. But then it will be easy to do it because once when it starts dilating, the taking it out and putting it even can be done under local anesthesia also.
Yeah, so the patients I've seen with that, they've come maybe in their teenage.
Yeah.
And by that time, it's, would you still try stenting and surgery to save the kidney?
No, see, the thing is, surgery, of course, is a more definitive treatment. So if you think that patient will not come for follow-up, or if it's not a local patient whom you can follow, you offer surgery, and if they're willing for open surgery, you can do open surgery. So now people even are able to do it laparoscopically. But then I wouldn't advocate laparoscopy because placing sutures at the correct place is very important. And you don't have such great control with the laparoscopy suturing. Okay. But if we have the big stents, that is also not a very good option because you just cut and you allow urine leak. And when there is a urine leak, that causes inflammation and fibrosis, and later on operating in that area will be very difficult. So it's not a very popular method. So, but then the least simple thing you can do is to put in a stent, because that will immediately relieve the obstruction and it will prevent further damage, and also gives the opportunity for healing. So after 2 years, if it heals, then fine. If it doesn't heal, you can still go ahead and do surgery. And another thing with putting in a stent and making it dilate is that it will help in doing the surgery also, because already instead of a tiny ureter, you have a much bigger ureter to suture. So that way also it is much better.
Okay.
Okay, so how do you diagnose the hydronephrosis or PVJ obstruction? So what are the tests you can do?
Ultrasound.
Okay, ultrasound will show what it will show. So what do you measure to sort of tell how much is the obstruction or how severe is the block?
So I think ultrasound will only describe the hydronephrosis.
Yeah, so and what else within? What are you looking for then? Hydronephrosis, even the patient will read and say there is hydronephrosis.
Yeah.
But you need to be a little more.
Yeah, I'm not sure the ultrasound will be able to tell a lot more. Maybe a CTKUB.
No, before that, ultrasound itself, what do you look for in the ultrasound?
Yeah, okay.
So you need to be one up all the patients. So the patient will read the hydronephrosis. So, Raseli, what else will you look for in the report?
When the column of the fluid there is more than 10, it's more than 1 centimeter when the bladder is empty. When the bladder is empty.
See, you need to look for the cortical thickness. Okay. So the first thing which happens is that as the back pressure occurs, it keeps destroying the renal parenchymal tissue or the nephrons. So normally it's about 2 to 2.5 centimeters, the cortical thickness. So that keeps narrowing. And if it is severe, massive hydronephrosis, it will be hardly just 1 or 2 millimeters will be the cortical thickness, and it will be hardly functioning. So that is the important parameter they should look for. And the other thing you need to look for is the size of the kidney, whether it is increasing. In fact, when I've treated hydronephrosis so big, it went to the other side and caused block of the other kidney. Primary problem is hydronephrosis and the left side, which went to the right side to cause block of the other right side. So it can really be huge, yeah. So it's important to look at this. So what is the normal size of the kidney?
About around 20 centimeters.
I can't hear.
About 120 centimeters. Huh? Between 90 and 120 centimeters.
Millimeters.
120 centimeters is huge.
Millimeters.
120 millimeters.
Yeah, it's around, it can be about 10 to 12 centimeters. Right. So which side is bigger, left or right?
Left is always bigger.
Okay. Left is slightly bigger, but it doesn't really matter. But if there is hydronephrosis, then it'll actually, the size will start descending. And then in any other test, if it's available, you can sort of measure how much block is there.
Yeah, CT urogram.
Okay, CT also doesn't really give you it'll just show there is a block, but it can't give any objective value. So what percentage of obstruction is there and so on. Is there any test that you can do? Especially in children, you can send them for some tests. Have you heard of isotope scans? So you do give an isotope scan to find out how much block is there. So generally, if the function of the kidney is more than about 20%, then it is worthwhile to preserve the kidney if it's a unilateral block. But then if it is only 10-15%, then and hardly any cortical thickness, it's better to do a nephrectomy. Why is that? Why can't you just leave it? Patient is not causing any problem, no pain. Can you just leave it? Do you have to do anything?
Any infection, to prevent infection?
Okay, so it's a bad, I mean, see, normally infection does not occur because it's everything is draining. We said normally we have bacteria in the bladder which doubles every 20 minutes. But we don't get infection because when you pass urine, most of it goes out. Similarly, kidney also, even though it's relatively sterile, there may be some bacteria. But if there is a block, if it is and if it stays for a long time there without emptying, then there is a chance of infection. So that is one very important thing. If it's infected, what do you call it? If there's no infection, it's called hydronephrosis. If it is infected, what do you call it?
Pylitis or something like that.
Pyloroplasty.
Pyloroplasty.
Okay, so because instead of urine, it has pus, so it's called pylonephrosis. Okay, so that needs draining, and that's a complicated this thing. So that is one complication. So what else? So another complication could be, as I mentioned, it can go and press the other side and cause hydronephrosis. That's a very rare complication. Okay, and then what are the other things which kidney secretes? So why is what are the other problems? Say especially if there is renal failure.
Erythropoietin.
Okay, so and what are the patients with renal failure? What are the other things which occur? Hypertension. Okay, so those sort of changes because the kidney is not functioning well. These can affect the kidney on the other side also. So if there is a kidney which is less than about 20% function, there is a good chance that it will affect the other kidney also. That is the reason why you need to remove the poorly functioning kidney if the other kidney is normal. But if the other kidney is also hydronephrotic, then you have no other choice. You need to keep doing something so that both the kidney function is for salvage for whatever reason. Okay. And this will, this DTPA scan or isotope scan will help you to decide what type of treatment you want to do, especially in children. Because it's going to be a lifelong affair and we don't want them affecting the other kidneys. So it is, especially in children, it's very important to do the isotope scan and find out how much function of the kidney is there. Okay.
I only read isotope scanning in school. I've not seen where it is being done here.
Is it? But of course, it will be done only in some places where they can have the isotope. It will be in medical colleges or whatever it is. If you don't have it, then you go by the cortical thickness. Say less than half a centimeter thick, then you remove it. Because that's an indication of that there's hardly any function there in the kidney. If the kidney is dilated, if the thickness is less than half a centimeter, then you have to definitely remove it. Another way of finding out is you put a stent and see what happens to the kidney size. See if the function is reversible, if the kidney is able to recover the function, then the kidney size will become small because anyway you are relieving the obstruction, and some function also will return once the obstruction is relieved. Okay. And how do these people with the hydronephrosis present? What will be the normal presentation?
Flank pain.
Okay, they can have some. What type of flank pain will be there?
Fullness.
Yeah, it's more a dull ache. Why is it? So why is the pain occur?
Stretching the capsule.
Pressure.
Renal capsule.
Yeah, so once there is any stretch to the capsule, it will occur. So normally, if it is very slowly dilating, then there may not be much of a symptom. But if there is some infection, some this thing, or suddenly there's some diuresis or whatever it is, then it stretches suddenly, then you have pain. But most of the time, when they are asymptomatic, they may not really have any symptoms. So when you do an ultrasound, then you might find that, okay, this kidney is hydronephrotic. Then, of course, when they have complications, so if they have pyloroplasty, they'll present with high-grade fever, chills, and all those things. Then if we have unexamined, it's an young adult, unusually very high BP or low hemoglobin and those sort of things, then we again do the investigations. So other than dull ache, there may not be much of a symptom as such. But of course, signs you may be able to palpate the kidney. Normal kidney, will you be able to palpate?
No.
It's difficult to palpate unless they're very, very thin patients. So if you are able to palpate the kidney, it generally means that there is something wrong. So that is one thing you need to be aware of. And any other tests you can do? I mean, the urine which is produced by the hydronephrotic kidney and normal kidney, do you think there will be any difference, or you don't think there will be much of a difference?
I don't think there's much difference.
Okay. At least the initial stages, there may not be much, but later stages. So one of the common thing which happens is that with the renal destruction, it becomes more porous. So they start leaking albumin. So you might have a higher albumin content, but these are all very minor things which not very significant. So you might have more urinary proteins and albumin loss in the affected side. But of course, it gets mixed with the normal side. So it may not, if you just check the thing, there may not be much of a difference. So how common is this?
Yeah, I think for me, I see more of those than even like bladder stones. I think maybe, let's say maybe at least 6 patients in a year or thereabouts.
Okay. What about Adeseli? How often do you see this hydronephrosis?
When I do ultrasound, I do see a lot. I never knew there could be any other thing that one could do. You do see a lot, so many.
But so the thing is, the incidence varies from, could be as high as in some places 1 out of 600 births. So 1 out of 600 people or 1 out of 1,000 people will have a PUJ obstruction, but it may not be very significant. It may not be complicated. So it is, I mean, it is a very high chance of you picking it up. So it's always good to do an ultrasound as, I mean, maybe even like a screening procedure. So ultrasound is something you need, I mean, if you want to practice urology, you should learn how to do it, because you can pick up hydronephrosis, you can pick up stones, both in the bladder, both into this thing. You can look at testicular tumors or renal tumors and all those things, or cysts in the kidney.
Yeah.
So ultrasound is a good investigation that you need to sort of learn. Okay, Dr. Sally, can you sort of summarize what you learned today about hydronephrosis? So what is tell us what is hydronephrosis?
If I could get you very well, about fluid collection in the renal pelvis, extending to the cortical tissue of the kidney.
Okay.
And there could be causes could be obstruction at the what do you call it now?
PUJ, pelvic uretary junction.
Yes.
Okay.
That it could be whether it could be real organic something.
Yeah, very rarely it can be a stone or stricture, but mostly it is congenital PUJ obstruction. Okay.
But you said in feti or fetuses that it could be due to some neurological anomalies that could cause such fluid retention that destroys the cortex.
Okay. Now, Dr. Elijah, you tell me the process of what happens. How much is the normal pressure in the kidney? What happens to the pressure in the kidney? How often the peristalsis occurs? What is the mechanism of developing PUJ obstruction?
Yeah, so normal pressure is about 10 to 15 centimeters of water. And what happens is because of this nerve issue, the PUJ does not relax, so
it's something like Hirschsprung disease. So
yeah. So it doesn't relax, and therefore you have back pressure in the renal pelvis that is now transmitted to the renal cortex. So you have cortical thinning and
slowly expansion. Dr. Sally, what will the patient present with? Common presentation, they have hydronephrosis level.
So dull ache at the flanks. Dull ache at the flanks because of stretching of the
okay, so the renal angle pain will be there. Then what is the most common presentation? It's an incidental finding. So they don't have any symptoms.
Yes, they don't have.
Okay, so then the next they can have a dull pain. Okay. Or they may be able to feel the kidney and say, okay, my kidney, there is some lump in the area where you can palpate kidney. Okay. So these are, or sometimes very rarely in a young patient, you can present with hypertension. So somebody with a young patient where you don't expect a very high BP, if they have a BP, then you need to check. Okay, so what investigation do you do, Dr. Elijah?
Yeah, so you do ultrasonography is one.
Okay.
Yeah, you can do isotope studies. You call it DTP.
Yeah, DTP scan.
Yeah, so that you can be able to assess the renal function.
Okay.
Yeah.
Okay, so Dr. Sally, what treatment will you offer? He says, patient says, okay, you're doing an ultrasound finding a kidney. I have no problem, I have no pain. Should I have treatment? He is asking. So what will you tell him?
You said I could put stent.
No. Patient says he doesn't want any treatment. What will you tell the patient that why does he need the treatment? Patient says, I have no pain. You only did the ultrasound and found it.
We explained to the person that it could gradually destroy the kidney.
Okay, it'll destroy the kidney then. Besides, I mean, people who had nephrectomy can live with one kidney. People donate kidneys. So what?
Okay.
So then what will we tell them?
That there could be other problems coming from the abnormal kidney affecting the normal kidney.
Okay, so it can affect the normal kidney because of the hormones and other things this kidney secretes. It can be life-threatening infection if there is a pylonephrosis or something like that. So you have to convince the patient that even if he does not have any symptoms, he still needs treatment for hydronephrosis. Okay. So then, Dr. Elijah, what are the treatment options which are possible that we offer to these people?
So treatment includes stenting.
Okay. But then you don't tell them because stenting you may not find in any book or it's a final thing. So
yeah.
It's for more for rural areas rather than standard treatment. So what is the standard treatment?
Mm-hmm. So stenting can be used as a temporal measure, but
okay, the standard
surgery is definitive there.
Okay, so see, the treatment is either you have a corrective surgery or pyloroplasty or nephrectomy.
Mm-hmm.
Okay. So how do you decide say whether you do a nephrectomy or pyloroplasty or conservative treatment that we can give?
If the cortex is less than half, the cortex of the kidney is less than half centimeter.
Okay, so the cortical thickness is very thin or less than half a centimeter, or if the kidney is huge and this thing, or if there is any pus or already there is some evidence of infection. Okay, so then you need a nephrectomy. And if they can do a isotope scan to find out the actual percentage of the function, if it is less than 15%, you do a nephrectomy. Okay. So then you have what are the three possible ways of doing pyloroplasty in the Elijah? Did Elijah able to hear?
Oh, sorry, I had muted myself. Sorry.
Okay.
Yeah. So you can do open pyeloplasty that is dismembered or non-dismembered.
Okay, so preferably dismembered, which is the Okay, then.
Sure. Then MIS pyeloplasty.
Okay. So laparoscopic pyeloplasty you can do then.
Yeah, and you can also do non-invasive.
Endoscopic.
Endoscopic, yeah.
Okay, so. But then, given the choice, probably the open one will be the best because that's where you have best control of this thing, and you can do. Okay.
So how do
you?
You usually do it from the flank incision, or?
Yeah, flank.
And how do you avoid devascularization? What tricks?
See, you need to realize that it's a very complicated blood supply or the ureter.
Yeah.
Okay, so you don't have to. I mean, you need to dissect only in the place where necessary, absolutely necessary.
Mm-hmm.
Okay, and also you need to be aware of the abnormal vessels which can cross.
Mm-hmm.
So the less dissection that you do, and if you're dissecting the right plane, and again, do not use too much of electrocautery.
Mm-hmm.
And again, you have to make sure that the suturing is accurate and tight because any urine leak a little bit that can cause significant inflammation and later on stricture.
Mm-hmm.
Okay.
Do you leave a drain?
Yeah.
Passive?
Hmm?
Passive drain or?
Yeah, you have to put in a stent and also leave a drain, tube drain you can do outside.
Okay. Okay.
Okay. And I mean, if the patient is available for regular follow-up and under your care, if it's a local patient whom you trust will come back, then the minimally invasive treatment is just putting in a stent.
Yeah. Okay.
But then it has to be done for a period of about 2 years to decide
2 years. Yeah.
whether there's any significant improvement or not.
Okay.
Okay. So any questions? Because we have another 5 minutes for questions.
I never knew that there are so many surgical opportunities in either urology like this. I never knew.
See, if you want, there is one video. I'll send you the link. You can see how to do a minimally invasive nephrectomy for hydronephrosis in a child. I'll just, this is one video which I recorded almost 10-15 years ago. We recorded. I'll send you the link later.
Okay.
Okay.
All right.
Okay, then you keep completing the lessons and try and get more people for the classes so that they also benefit. Okay. Okay then. Bye.